So my name's Gareth Baynam, I'm a clinical geneticist and I direct the Undiagnosed Diseases program of Western Australia. We use genomic testing predominantly for diagnostics. We went from a 10% diagnostic rate for our kind of hard to solve cases to a 30% diagnostic rate in 12 months. I haven't had many experiences in medicine of tripling something. It may have been months or many years or decades of uncertainty, of not knowing what the cause of a person and or a family's particular condition is. Once you can remove that uncertainty, it gives you the clarity for medical management for that family potentially. It might hook you into best practice pathways. Sometimes there might be disorder-specific treatments based on that diagnosis, still a minority of instances. There may be drug repurposing, and I think we're seeing that more and more. Once you know exactly what you're dealing with, then you have a better opportunity to create communities. So those communities might be the level of a patient and their family. So suddenly if you have an answer, you can connect to other people who have the same condition, who are experiencing similar things in their journeys. It also removes isolation from medical staff, in that many times lots of people are trying to get an answer and have tried for a long time. And once you, and particularly if you do it together, get an answer for that, that creates another sort of community. The technology in and of itself is fantastic, but it's empowered by how you use that technology, how you select which cases to test in and what situation to test in, and how you inform that test. I think it comes down to pretest probability. In a rare disease space, those red flags are things like, I think the big ticket one is, this is a complex multi-system disorder. Is there a combination of birth defects, a combination of congenital anomalies? Is there severe intellectual disability? Are there, frankly, just really abnormal results on your blood tests that are perplexing? And then what's the family context? In a lot of ways, the cheapest and most portable genetic test you can do is a family history. People react very positively to a clear pathogenic variant in the settings at which they've been looking for one. But sometimes even in those settings, the black and white of an answer can be challenging in that kind of new normal kind of sense. So I think variants of uncertain significance and their burden is probably one of the key challenges for genomic medicine, and maybe the key challenge. They can be an opportunity cost because they distract you from the underlying cause, either because you're just spending time trying to clarify that, or because you inadvertently and with all the best intentions and all the highest efforts misattribute the cause to that variant. And then because of the familial nature of genetics, you might then be using that information for a brother, a sister, a mother, a grandmother, and suddenly that's a magnifying cost for the family and through the health system. One of the challenges, and I think this is also one of the great opportunities in genomic medicine, is about underrepresented populations, and in particular in Australia, Aboriginal and Torres Strait Islander people. We have the capacity, the ability, if we do this right, to bring Aboriginal and Torres Strait Islanders together in partnership with us, at least at the same rate as other people, maybe even ahead